All right, we're going to start the second panel. And I'm Ann Montgomery. I'm going to be moderator for the second panel as well. Larry Polivka really wanted to be here, but unfortunately Delta did not deliver him here on time. So I will have the honor and the privilege of introducing our second panel. And for this second panel, we'll build on the discussion, which I thought was really excellent, of the first panel, and really do a deep dive delivering long-term care at the state and community level. And to do that, we have three absolutely outstanding panelists. The first is Josh Wiener. He's Senior Fellow and Program Director for Aging, Disability, and Long-Term Care at RTI International. I tend to think of Josh as the Dean of Long-Term Care. We have Joanne Lynn. She's a geriatrician, a doctor. She's Director of the Center for Elder Care and Advanced Illness at the Altarum Institute. And we have Martha Roherty, the Executive Director of the National Association of States United for Aging and Disabilities. So with that, I think we'll start with Josh, and come on up, Josh.
Thanks, Ann. I always wanted to be a dean. So I'm going to be talking about state initiatives in long-term care, where have we been and where are we going with that. And while a lot of policy is discussed in Washington and at the national level, states are really where the rubber meets the road. It's states that license and inspect long-term care providers. They decide really what's covered and not covered under Medicaid. They set reimbursement rates, and so they really determine the contours of long-term care policy. And within that, Medicaid and Older Americans Act programs really are the bulk of the funding. In the first panel, we talked a lot about what is being done under the duals demonstration, so I'm not going to go there. But what I'd like to do in my limited time is give a little background on financing for long-term care, especially from a kind of state perspective, and then talk about what states are doing in terms of delivery system reform, a little bit on financing reform with a focus on some of the initiatives in Hawaii, and then talk a little bit about what this might mean for the future. So overall, we spend at least $211 billion on long-term care in 2010. As Don Redfoot of AARP has pointed out, these traditional figures don't do a very good job of capturing funding or financing for assisted living facilities and other residential care facilities. But this is sort of the basic contours. And as you can see, the elephant in the room is Medicaid, accounting for about 62% of long-term care expenditures, and other public, which would include Older Americans Act and the Veterans Administration, accounting for 5%. So sort of following back on to the question I was asking in the first session, I think a question is kind of what is the relationship between these smaller programs like the Administration on Aging, Older Americans Act programs, and Medicaid, because it's really Medicaid that's driving the train. So looking at Medicaid, I think it's always useful to get a little bit of a historical perspective. And if you look at, compare 1988 and 2010, total Medicaid expenditures increased by about 750% over that time frame, despite the aging of the population and a lot of projections that build on a growth in the elderly population. Long-term care expenditures increased by about fivefold, so much less than the overall program. And I think the basic differences are the non-elderly, non-disabled population that has increased as a result of the recession, but also younger people with disabilities and their acute care expenditures. We tend to forget that people with disabilities have substantial acute care expenditures as well as long-term care expenditures. So, and if you look at the long-term care expenditures, while the institutional care did increase substantially over that time period, it's really the growth in home and community-based services that has driven a lot of the expenditures for long-term care. So home and community-based services waivers, which we now have kind of in our blood in terms of the financing of the system, in 1988, less than $1 billion in expenditures, now nearly $36 billion. So thinking about delivery system, I want to talk about sort of two broad things. One is this effort to expand home and community-based services and to change the balance of the delivery system. And we've got really a bipartisan, nonpartisan consensus on that, and we're making substantial progress in that direction. And so we have a set of states, including Washington, Minnesota, Oregon, Alaska, California, New Mexico, where a majority of the long-term care expenditures for the aged and disabled are for home and community-based services. And when it comes to the population with intellectual developmental disabilities, 2/3 of expenditures are now for home and community-based services. As Carol Reagan was alluding to during the question period, really part of that we really haven't very successfully addressed is that if we're doing this kind of expansion of home and community-based services, of people providing those services out in the community, we really haven't done a very good job in terms of either recruiting people, training them, giving them feedback, and doing what's necessary to get the highest quality care. And that's especially going to be a problem and an issue when we come to the integration of acute and long-term care. So this is sort of what has been happening with Medicaid long-term care spending for home and community-based services for the aged and disabled population. In 1995, that was 18% of total Medicaid long-term care expenditures. In 2010, it's 35.7%. It kind of leveled off during the height of the recession, and it's going to be very interesting to see if we go back on that increasing trajectory, or whether, given fiscal constraints, we now are sort of leveling off. So one of the things that has been happening is and it's not widely appreciated, is that on a population basis, nursing home use has fallen pretty rapidly. This is a graph of nursing home residents per 1,000 elderly aged 75 and older over time, and as you can see, it's dropped pretty substantially. And so the $50 billion, $100 billion question is there a relationship between the expansion of the home and community-based services and this drop in nursing home use? And I think the answer is the jury is still out. So this graph on the y-axis is the nursing home residents per 1,000 elderly, age 75 and older, and the horizontal axis is Medicaid spending for home and community-based services per 1,000. So as you can see, the regression line shows a slight decline in the line, so that means that as you spend more, that nursing home use declines, but it's not a sharp decline, and you have to spend a substantial amount of money to get that decline. Moreover, I like to describe this regression line as a line that only a real economist could love. There's an awful lot of noise there, and if you took out a couple of data points, you could make the line be pretty flat. So the other part of of what's happening on home and community-based services is really a fundamental change in the paradigm, away from agency-directed services towards consumer choice and empowerment. And there are really kind of four main elements to that. First, James didn't really talk about them, but the Administration on Aging has been putting a lot of money into aging and disability resource centers to try to be a single point of entry for both older people and younger people with disabilities into the long-term care system. So this fragmented delivery and system that we have becomes much more understandable from a consumer point of view. The second is participant direction. Third component is money follows the person. And the fourth is the expansion of residential care facilities. So I've already said a little bit about these aging and disability resource centers. Basically, virtually all states are doing this. They vary in the extent to which they are really a single point of entry, but that's the goal. I've been doing long-term care since the mid-1970s, and it has always been the dream that there would be this single point of entry that would coordinate care and do care planning. So the second component is consumer direction. Under traditional home and community-based services, agencies hire, fire, direct, train, and schedule the workers. And in consumer direction, it's the individual consumer or their caregivers that really do that. So this was originally advocated by younger people with disabilities, but later adopted by advocates for older people as well. And so a large number of states, the United Kingdom, the Netherlands, Germany, a large number of other countries are doing this as well. In the United States, these workers tend to be family and friends, which raise a number of quite difficult issues in terms of the extent to which these workers or these caregivers are need to be thought of in terms of kind of regular workers, and to what extent they need to be thought of as family and friends, and therefore people who provide a substantial amount of informal care. Money Follows the Person is another major initiative. It predated the Affordable Care Act, but certainly got a major additional boost from that. And this, too, is a major kind of paradigm change. From the beginning of my time in doing long-term care, the goal was to try to divert people from going into a nursing home or some other institution, but once they were there, you pretty much kind of gave up people for lost, and that was just kind of the end of the story, and the institutions took care of people. So what Money Follows the Person tries to do is identify people in institutions who can live in the community, provide them with the supports, the transition supports, and supports into the community that would allow them to live there. So this is a demonstration that virtually all states are participating in. There are extremely generous financial incentives from the federal government in terms of Medicaid to try to support that. And I think it certainly is this major paradigm shift. To date, they haven't managed to transition out a very large number of people. Over the roughly 4 years in which this demonstration has been underway, they've transitioned about 25,000 people, but there are perhaps 4.5 million people who have cycled through nursing homes during that same time period. One of the big barriers is housing, and that's a key issue. Oops. Residential care facilities, these are assisted living facilities, although there are a number of other non-medical residential settings as well. Most of the funding is private, but Medicaid counts for about 20% of residents, and it is fundamentally regulated at the state level rather than the federal level. And so one of the key issues is, are these residential settings really institutions, or are they home and community-based services? And that's more than just an academic question, because CMS is currently considering regulations to define what is home and community-based services, and it's to the extent that they have a very strict definition, then some of the facilities that currently participate in Medicaid may not be able to do so. So this graph shows some of states' participation in some of the key Medicaid provisions of the Affordable Care Act. We've had a moderate level to a fairly high level of take-up. It's still, I think the jury is still out in terms of what states are doing with this. Many of these provisions have a higher match rate, and I think a number of states are basically refinancing existing programs to get that higher match. But again, the jury is still out, and it's too early to say. So turning now to financing, not very much has happened on financing over the last 15 or 20 or 25 or 30 years. But we do have some states that are beginning to do things. And one interesting case is Hawaii. In 2003, the state legislature passed a law to establish a public long-term care insurance program. It was vetoed by the governor. The Hawaii Long-Term Care Commission in 2012 recommended that work be done to try to see whether or not a public long-term care insurance program should be implemented in Hawaii. If it was feasible, they recommended it in principle. They saw it as financed by modest mandatory premiums. Basically, everybody would have to pay who was in the workforce and under the age of 60. There'd be no medical underwriting. People would have to pay premiums for 10 years before being eligible, and there would be a modest benefit. It would only cover 1 year of services or 1 year of benefits, and the benefits would be cash at $70 a day. So in some ways, this could be thought of as a kind of fixed-up class program in terms of something that is to be made mandatory. So just to conclude, Medicaid and long-term care is much higher on the public policy agenda at the state level than it has been at the federal level. States have made a lot of progress in terms of delivery system over the last 20 years. There's been less progress in terms of financing, and that the reason for that lack of progress is conflicts over public versus private financing. Now, where have we ever heard of that conflict before? So it existed on the healthcare side, it exists on long-term care. So as with health reform, I think we have to look to the states to sort of start the ball rolling on both delivery system and financing side, and then giving, once the national government sees that something can be done, they can think more broadly about implementing that on a national level. Thank you.
Hi, I'm delighted to be among you. I'm looking for some advice on this, so I'm hoping you'll weigh in. How many people here hope to grow old? Okay. How many want to die after a period of frailty with serious disability? How many think they will? Oh, come on. It's now more than half of us. We'll have more than a few years of serious disability at the end of life. We did not have this population or this piece of our lives just 50 years ago. We have not designed a care system that makes sense for it. And I've come to the conclusion that it isn't just federal and state. We need a local entity. So let's see how that goes. First, recognize that there's lots of different people who need long-term care. I'm only going to be talking about frail elderly people. Now, I realize that some of the other groups may well come into that mix, and there are many of the same issues and many of the same services. But it is different to live with serious disability and decline in the shadow of death than it is to live with a fixed disability which you will live with for many, many years relatively stably. So let's build on the frail period of our lives, which most of us will get, and those of you who don't get it will get it because you die young. Now, I'm a geriatrician, so young is maybe under 85 or something. So people who die with a heart attack at 72 or a stroke at 78 or cancer at 75, those are all young deaths for me. Most of us have made it past, driving as teenagers and probably not in the military. So we are doomed to die of chronic conditions. Chronic conditions tend to kill you by 1,000 cuts in old age. And in old age, past 80 or 85, that doesn't matter what the doctor labels you as, you have a very high likelihood of self-care disability for a substantial period of time. What's that average now? In the Health and Retirement Survey, it's hitting 3 years as a median. 20% get more than 7 years. So plan ahead, folks. Salient facts about how we live at that part of our lives. First thing is the world becomes much smaller. You must have services where you live. If I got terribly sick, I could go to Mayo for a second opinion. If I need spoon feeding 3 times a day, it's got to happen where I live. You got to have somebody skilled and be able to do that, able to show up at my house regularly in order to be able to be fed. Your services have to be mobilized to where people live. The numbers will greatly increase. Everybody's all excited about the boomers turning 65. That's trivial. The big issue is, when do they start turning 80? When do men start turning 80 and women about 85? And that's when we'll start seeing the really steep rise. The frailty and old age now accounts for about half of your total lifetime costs. It's hard to estimate that exactly, but when you start adding in long-term care costs and caregiver costs and loss of opportunities for your family caregivers or nursing home residents, it's really easy to make the case that it's around half. Almost no one has the savings or insurance to do that. How many people here are confident that you can live through, say, 3 years of self-care disability for you and your spouse or your partner, if you have one, and not be bankrupt? How many? I have one hell of a long-term care policy. I've been there. There are, what, 3 or 4 of us? The rest of us are duals in training. It's just a matter of how long you'll live. If you get an illness that kills you in a year, you'll make it out with your estate still intact. If you instead get something that takes 6 or 8 years, you won't have enough assets, you will be poor. There is no way to change this now. There's no way in the current environment in which even 55-year-olds could save enough by the time they retire to cover their own long-term care costs. So if we are going to not abandon one another, it's going to have to be by collective action, because there's no way for individuals who right now face this issue to have saved enough to get through this period of life on their own. So we have to have societal investments. I don't care if you're a far right winger, a far left winger, whatever else, unless you're willing to have your high school teacher a beggar on the streets, you're going to have to figure out how to provide housing and food. You're going to have to provide at least minimal clothing, direct care services, and some medical care. The current practices are abominable. Almost everyone who goes through this period of life with a loved one has these incredible stories to tell of how terrifying it was, how nothing made sense, how the costs racked up, how no one told them what they were facing. How many times have I sat in a hospital listening to the residents say to a family, "Oh, you'll just have to wait to see how she does." By damn, we have the data. We could be telling people with a stroke as bad as your mother, only 30% are alive in a year. The rest are in a nursing home. We don't tell people that, and they don't ask because they don't think we even have the answers. They think that we're telling them the truth. You have to wait and see. Well, you know, that's just not going to hold up. Everybody's got those phone apps now. They're going to be able to dial right into Archimedes and dial it up. We're going to be able to know what we face. We're going to be able to realize what a terrible care system we've got. And then, of course, we screw up the whole thing by being unable to acknowledge that the end point of multiple chronic conditions and frailty is death. I mean, there's no other way out. Nobody who has become terribly frail in old age is suddenly vibrant in 22, you know? But we have to develop the language that allows us to talk about that. And this is the thing that I think pushes us over the edge in a sense of urgency. This is from Aging in the Macroeconomy, the marvelous report out of the National Academy of Sciences. This was the total US consumption curve in 1960. That little yellow line up there, that's private spending on healthcare. That tiny little pinkish line above it, that's public spending on healthcare. Look what happened by 1981. That piece over to the far right, that's older folks, 60 to 90 especially focus on. Look how much that's grown with Medicare being available. And now look what happened by 2007. That little line running across that says 1, you know what that 1 is? That's the maximum productivity of your peak productive years. That means that there is no way for the US economic engine to afford to double the expenditures from the 60 to 90-year-olds. We are already at the peak productive, and we are going to be way over it by just doubling the numbers of people. If you think that we can stay with what we're doing now, not only do you condemn us to living through the chaos and expenditures of the current care system, but you condemn the economic engine to oblivion. So I think that we have to figure out how to manage the system. We have to figure out how to manage for efficiency. I am driven crazy by those new ads on CNN that show you, how to request Provenge from your doctor. $100,000 drug, $100,000 drug, freely available to any Medicare patient at a time when we cannot guarantee them housing. Think about the enormous disproportion of having to send people home to thoroughly inadequate housing, inadequate nutrition, inadequate direct care working, but being able to get a $100,000 drug, which gets you, anybody want to guess? How much longer do you live with Provenge? 3 months longer on average for people who are in perfect functional status with no symptoms. It's never been studied in anybody else, but I can order it up on my most disabled, most demented, most withdrawn nursing home patient, and it will be paid. But I can't get Meals on Wheels on a weekend. By damn, I can't even get Meals on Wheels on a weekday now. Almost all of the country has a waiting list. We cut 20 million meals out of Meals on Wheels in a flash with the sequester, and no one's marching in the streets. Where's our sense of what's important here? Food is important. Provenge, not so much. Nor the other 5 or 6 chemotherapy drugs that are now running in the same cost range. So I think the way out is to build a new layer of management that every other country has, and we do not. We have the magical sense that somehow Montgomery County's elder care is going to work just fine if the incentives could be set up right in Annapolis and Baltimore. We think that that could even be done with Sacramento and California. There's no way. We have to be able to get to a local level. Localities can build on volunteerism, can understand their geography, can make some trade-offs, and it's politically plausible. This is beginning to get some uptake. This is the working